Hello, so today we're going to talk about the anti-anginal drugs. This presentation is mainly aimed for medical students and junior doctors. So we're going to cover the following 6 sections. The first section that we're going to cover is the definition of angina. Number 2 is the pathophysiology of angina. 3 is the types of angina. And 4, how does the anti-anginals work? 5 are the classes of anti-anginals, and 6 is the ECS guidelines. So let's start by the definition of angina. So angina is basically a symptom, and it's actually one of the most common symptoms that presents to the hospitals. So if you look over there, this is the traditional classification of suspected anginal symptoms. So if a patient comes to you saying like they're having chest discomfort or pressure-like sensation in the front of their chest, neck, jaw, shoulder, or arm, other 2 criteria must be there to confirm it's 100% angina. So the other 2 criteria is, it says like, well, it actually gets worse when I exert myself, and also plus minus emotional stresses. Number 3, it's basically relieved by rest or nitrates within 5 minutes. So if he's got all these 3 criteria, so this equals definite angina. If a patient, however, tells you that they basically have 2 of these criteria, let's say it's not relieved by rest or nitrates, or it's not really precipitated by physical exertion, but it's having the same nature of the pain or the discomfort, then this is atypical angina, which is probable angina. If they don't have any of these criteria, or only one, that means straight away it is non-anginal chest pain. So next we're going to look at the pathophysiology of angina, and this is essentially we're looking at the coronary vessel. So the pathophysiology of angina is basically one word. It's oxygen mismatch. It's either decreased oxygen supply or increased oxygen demand, or a combination of both. If you have all of this, then you will get anginal symptoms. So the types of angina that we have in here is basically 3 different types. The circle in here represents the coronary artery, and the rectangle in here represents the myocytes. The yellow bit in here is a plaque. So let's talk about the first type. The first type, you can see the plaque in there is stable and the myocytes are fine. But let's say if there's any increased oxygen demand, like exertion, going up hills, running, then the patient will start experiencing symptoms of angina, because there is now the oxygen demand is higher and the slightly narrower vessel is not able to supply it. This is called stable angina. So the patient actually gets the symptoms when they exert themselves, whether that's an emotional, whether that's physical exertion, by increasing oxygen demand. Let's look at this one. As you notice over here, the lumen is slightly narrower compared to the other vessel. So it's basically vasospastic. The vessel is getting tighter, so it's vasospastic, or what we call as well as Prinz-Metal, or variant angina. This typically happens, basically, the typical features is essentially most of the time it's a female, smoker, and usually happens early in the morning when there is catecholamine surge. So essentially the problem here is not the oxygen demand, it's the oxygen supply, because the vessel is a bit narrower. Now let's look again at the same vessel. Let's look at this plaque. This plaque has fissured now, so it's no longer stable, and this fissure caused a bit of platelet aggregation. So there is a decrease, as you notice over there, the lumen is more blocked with a bit of clot, a bit of plaque, so there's a bit of decreased oxygen supply, and this doesn't really necessarily have to happen at rest because the lumen is a bit narrower. So oxygen demand also will make it worse, but the major issue is the decreased oxygen supply. This is called unstable angina. And since we've taken it that far, let's talk a bit about the rest of the ACS. We're going to talk about the ACS as well. So if you look over there, this is again the same plaque, but it's got way worse, and it's got more clot that the vessel is almost occluded, but not 100% occluded. So there is a severe decrease in the oxygen supply. Also, let's add to this bit that usually it sends a bit of feeder vessels to supply the deep bits of the muscles. So the top bits are going to be ischemic, they're not getting enough blood supply, but these bits in the bottom will not get any blood supply and they will be infarcted. Infarcted means dead. And once they are dead, they start releasing troponin, which is the enzyme in the heart. So this is basically will have some ECG changes. That ECG changes are really non-specific, could be T-wave inversions, ST depressions, all suggesting of ischemic ECG changes and a troponin rise because of the infarcted muscle. This is called non-STEMI. Now let's look at the same vessel again, but now the clot has got, sorry about that, now the clot has got way bigger than it should. Now it's a massive clot blocking the whole artery. So it's essentially zero blood supply. There's no blood supply whatsoever, and this whole area will be infarcted. And what you notice is obviously the troponin will be increased again because it starts to be released, and then will be ST elevations. So this is called STEMI. This is very serious and needs to go to the cath lab very quick and very soon. So now we're going to talk about the ACS briefly. So ACS is essentially acute coronary syndrome. The acute coronary syndrome does not include the first two that we talked about, which is stable angina because it's stable, it's not acute. The vasospastic or Prinzmetal angina does not include it in the ACS. So let's say that the patient comes in with a chest pain, severe, typical cardiac and sounding chest pain. You do an ECG, and the ECG will either show two things. The first one shows ST elevation. That needs to go to giving some antiplatelets and go to the cath lab to open this artery and stent it. If it doesn't show no ECG changes, then the next thing that you're going to do is you're going to do the enzymes, which is the troponin. And if the troponin is raised, then that's going to be non-STEMI. Troponin is normal, then this is going to be unstable angina. Because remember, in unstable angina, as you can see over there, there's no infarction. So you will not get raised troponin. Right, so now we move to the next bit, is how does the anti-anginals work? If you look at this picture, you forget the picture on the right first and focus on this poor donkey. Let's say that this poor donkey has a job to take some weights. So we're preloading this donkey with lots of weights, and we're asking him to go uphill. Yeah, and not just that, and every time he goes uphill, he drops a bit, and then we add more weights of the weights. If the donkey, we ask him to go like 130 times back and forth, it goes back and forth 130 times. It's going to be very, very exhausting. So the first factor that we need to look at is the preloads, which is the weights that he's carrying. So the less the weights, the easier it is for the donkey to go uphill. And then the next thing that we're going to talk about is the slope. So let's say that this slope is less. This slope represents resistance, which is after load. So if you decrease the resistance or make it more flat, it's going to be easier for the donkey. The last thing that we're going to talk about is the number of the times go back and forth. If you make him go back and forth 60 times, it will be much easier. So essentially you've noticed there are three factors to make the job easier for the donkey. These three factors were preload, decrease the preload, decrease the afterloader resistance, and decrease the number of the times, which is essentially decrease the heart rate in this scenario. And that's how anti-anginals are supposed to work. If you look at this picture now, then what you do is the same principle. You go to the venules, you dilate the venules, then you decrease the preload going to the heart. Venodilation. That's one of the mechanisms. The second mechanism is you decrease the resistance by working on the arterioles, decrease afterload, which is arterial dilatation. And then the next and the last one, as we talked about, is decrease the contractility and the heart rate. So look at this heart, and this is the SA node. So to decrease the number of the beats of the heart, or the number of the times the donkey has to go back and forth, or the numbers of times the heart beats, you can do that by calcium channel blockers, or by having beta blockers. So the way I drew this as a shield, because the beta blockers work by blocking the epinephrines acting on the beta receptors, so it actually slows down the heart rate. And if we look at this as the myocardial cell, and how strongly it contracts is based on the calcium channel goes in, and the beta receptors actually help to load the calcium to the myocytes. So if you block the calcium, which is calcium channel blockers, or block the beta receptors, you're going to have decreased contractility of the heart. And if decreased contractility, you're essentially causing decreasing stroke volume, decreasing cardiac output, decreased cardiac work, and decreased oxygen demand. So essentially it's the same two things. You're decreasing the oxygen demand for this. You're decreasing the oxygen demand. So now let's have a look and see the other factors that we're going to talk about. There's obviously other things that helps, but we're not going to be talking about, which is basically modifying risk factors for atherosclerosis, which is basically the plaque formation that we've seen. That includes stop smoking, statins, and activity. Stabilizing the plaque, which is against statins, to avoid it from fissuring and having all of this troubles and rupturing of the plaque that we mentioned earlier over there and there. And then the third thing that we're going to talk about is antiplatelet aggregation, antiplatelets. But we're not going to be talking about any of these drugs today. We're just going to be talking about anti-anginals. So the three basic anti-anginals that we're going to be talking about in details, which is essentially nitrates, beta blockers, and we're going to be talking also about the calcium channel blockers. Others that we're going to talk about are the second line, which is essentially ranolazine, nicorandil, and trimetazidine. So the first group of drugs that we can talk about are the beta blockers. So the names of the beta blockers that you probably know are atenolol, bisoprolol, metoprolol, propranolol. Propranolol specifically we're going to talk about differently because it's non-selective beta 1. So it's beta 1 and beta 2. So let's refer back to the diagram that I drew earlier when I was talking about how the anti-anginals work. So it works in the SA node and on the ventricular myocardium cells. So as we say that, and it blocks the epinephrine act on the beta receptors and thus causing decreased heart rate. And decreased heart rate causes decreased cardiac output. With the ventricular myocardium as well, that we said that it basically causes decreased cardiac output by decreasing contractility, and then the outcome of decreased the cardiac output is decreased cardiac work. If you decrease the cardiac work, then you decrease the oxygen consumption, and thus you ultimately cause decreased oxygen demand. An important thing when you say as a side effects or the potential side effects or things that you need to be cautious about when you're using the beta blockers is if you cause decreased heart rate, you need to be cautious in the cases of bradycardia. Be very cautious about it. And if you decrease the contractility, you add the cardiac output, you might decrease the blood pressure. So be careful in cardiogenic shock when using beta blockers. A couple of other things that we're going to talk about when you talk about these potential side effects or the complications of this medication is basically if you go to the lungs over there, beta 2 receptors. Specifically, when we talk about the beta 2 receptors, we're going to talk about the drug that we talked earlier as a propranolol, causes bronchospasm. So be cautious in using in the case of asthma patients. Also, another thing that you need to be cautious about is the hypoglycemia. Because normally when you have a hypoglycemia, it basically activates CNS to activate the sympathetic system to make you aware that there's something going wrong. And how does it do so is by increasing the heart rate, diaphoresis, to give you a sign that there's something going wrong. And with the beta blockers, it masks this effect, causing hypoglycemic unawareness. So these are one of the things that you need to be also aware of. Now we're going to be talking about the mechanism of action of nitrates. So the essential mechanism of action of nitrates to help with decreasing angina or helping with anginal symptoms is basically decreased oxygen demand. We say mostly because there's other tiny mechanism of action which can be causing increasing oxygen supply, but predominantly it acts by decreasing an oxygen demand. How does it decrease the oxygen demand? So essentially, let's look at the picture of the heart and blood circulation. Let's zoom in to the venous smooth muscle cell. What happens is the nitrates change into the nitric oxide. The nitric oxide acts in the guanyl cyclase enzyme, and this converts the GTP into cyclic GMP. The cyclic GMP is then acted upon by the myosin phosphatase, removing the phosphate from the myosin to the myosin light chains, causing it to relax. So simply, if we just ignore all of this, the nitric oxide causes relaxation of the venous smooth muscle. So what happens when you dilate the venous smooth muscle? So when you dilate it, there will become venous pooling. And when there is venous pooling, that means there is less venous return to the right ventricle. Less venous return equals decreased preload. And once we know that there is less or decreased preload, as the example that I mentioned earlier with the donkey, once you have less effort in the heart, it actually improves angina. How does it do so? Decreasing preload equals decreased stroke volume and then decreased cardiac output. then decreased cardiac work, to the outcome of decreased oxygen demand. Also, when you decrease the venous return, that means that you decrease the end diastolic volume, and then you decrease the stretch on the heart, decrease contractility, and then you again decrease the oxygen demand. This is essentially how it works by decreasing the oxygen demand. Something which is very important that you need to know as well, that with the expected decrease in the venous return, you expect some side effects like orthostatic hypotension, because there's more pooling of bloods in the veins. That means that you are likely, once you stand up really quickly having nitrates, you might have an orthostatic hypotension. Then also the dilation of the veins can result into headaches and flushing. And then also you need to use it very cautiously with the right ventricular myocardial infarction. So with the right ventricular myocardial infarction, this ventricle is not able to pump blood to the heart and to the left side of the heart in a good way, because it's actually infarcted. If you venodilate, that means you decrease the preload further, you would result into a more and more significant drop in the blood pressure. So it's generally avoided or not used in the case of the right ventricular infarction. Also, something that you need to be very aware of is the tolerance. So once you use nitrates, there becomes desensitization of the guanyl cyclase enzyme. Desensitization of the enzyme, and then by that time how powerful the mechanism of action of the drug is becoming less and less, which is also known as tolerance. Another caution which you should be aware of is when using it with PDE inhibitors, and that the most common PDE5 inhibitors used is sildenafil. As you can see from there, the PDEs essentially inhibits converting of cyclic GMP to GMP. So that's increase of the cyclic GMP, causing the outcome of more relaxation. You would have, with that, significant drop in the blood pressure. The next class of drugs that we can talk about is the calcium channel blockers. Calcium channel blockers are divided into the non-dihydropyridine calcium channel blockers and the dihydropyridine calcium channel blockers. So the non-dihydropyridine calcium channel blockers, they include verapamil, diltiazem. The dihydropyridine calcium channel blockers, amlodipine and nifedipine, are the two most famous ones. You can see here there are 4 different cells: the nodal cells and the contractile cells, the arterial smooth muscle cells, the coronary smooth muscle cells. All of them have something in common, which is the calcium channels. So the non-dihydropyridine mostly act on the top 2 cells, the nodal cells and the contractile cells. While the dihydropyridine calcium channel blockers act on the arterial smooth muscle cells and the coronary smooth muscle cells. Having said that, the non-dihydropyridine, which is verapamil, diltiazem, have some effect on the arterial smooth muscle cells, the coronary smooth muscle cells. So let's see the mechanism of action. So if they block the calcium entry in the nodal cells, they would cause, again, decreased heart rate. Decreased heart rate equals decreased cardiac output. Blockage of the calcium channel from entrance to the contractile cells, decreased contractility. And since you have decreased contractility, you have decreased stroke volume, and then decreased cardiac output, decreased cardiac work, and decreased oxygen demand. Now, if we're going to talk about the arterial smooth muscle cells, if you block the calcium channels, you will result into vasodilation. And when you result in vasodilation, you result into decrease the afterload, decrease left ventricular work, and thus decreased oxygen consumption. Coronary smooth muscle cells, if you block the calcium entrance, you cause vasodilation, which causes increased oxygen supply. This is really helpful, this phenomena, in treating of the vasospastic or Prinzmetal angina that we talked about earlier. So this is exactly how the mechanism acts. Now, if you're going to think about the potential side effects or harms of using it, clearly if you see decreased heart rate, then it can cause bradycardia. And if you decrease contractility, then you're not supposed to be using it in heart failure. Also, one more thing that you should be aware of, if you decrease the systemic vascular resistance, you decrease the blood pressure, which is the action on the arterial smooth muscle cell by the vasodilation, there might be reflex tachycardia. One last thing to mention, that you should not use the non-dihydropyridine ones, the verapamil and diltiazem, with beta blockers. Now we're going to be talking about the mechanism of action of ranolazine, which is really an interesting drug. As you can see, that this is the myocyte and this is the sodium channel. It brings the sodium from extracellular to intracellular. Increase in this sodium intracellularly results for it to be exchanged with the calcium and thus increase the intracellular calcium, causing increased contractility. This mechanism is very enhanced by the cases of ischemia, increases the sodium intracellular and the exchange for the calcium, causing increase in contractility. So this increased contractility is a problem because it causes sustained contractility, specifically during diastole. And the problem with that is because during diastole, this is when the coronary artery gets its blood supply. So if it increases contractility, it means it increases the diastolic wall tension, since it's in a sustained contractile state, and that also causes increasing left ventricular and diastolic pressure. All of this causes to what can be seen here in this diagram with microvascular compression. So microvascular compression, imagine that these are the small microvessels, and this is the muscle wall. It's very tense, causing lots of pressure and compression on these tiny vessels, and thus results in decreased oxygen delivery. What happens with the cases of ranolazine is it inhibits this late stage sodium channel. This is the ranolazine. So what it does, it decreases contractility, and once it decreases the contractility, it decreases the diastolic wall tension, decrease LVEDP, and better oxygen delivery. Ranolazine have side effects, and one of these is lots of drug interactions through the cytochrome P450. It also, since it's a sodium channel, it causes prolonged depolarization, and that can cause increased QT interval that might result into a serious arrhythmia called torsade. Now we're going to briefly talk about three other drugs, the nicorandil, trimetazidine, and ivabradine. So the nicorandil basically have two mechanisms. Essentially results into opens the ATP sensitive potassium channel, and stimulates the increase the CMP via stimulating the guanyl cyclase. And this causes hyperpolarization, results into the relaxation. And with the relaxation, we relax all the arteries, including the veins. So decrease preload, arteries or arterioles decreasing afterload, and the coronary arteries themselves. So better oxygen delivery. The trimetazidine is basically inhibits fatty acid oxidation and thus results, after you look at all this process, in decreasing the ATP, causing decreasing the contractile function. And it's used for that purpose. Ivabradine essentially decreases the heart rate. I'm not going to talk much about the ivabradine since it's essentially an antiarrhythmic medication that will be described a bit later in details. Now, looking at what you can find in the ECS guidelines is essentially the expected way that you start the therapy where the patient comes in with a prophylactic for angina. If a patient comes in with this angina and then with a long-term prophylaxis, you're starting prophylactic therapy, you start usually with beta blockers or calcium channel blockers. Then if the patient is not really working, if it's still getting the symptoms, then you add beta blockers and dihydropyridine calcium channel blockers. Remember, you don't add the non-dihydropyridines because they also cause decreased heart rate, will cause significant bradycardia. So you use amlodipine or nifedipine in this case. If that still doesn't work, then you add nicorandil, ranolazine, or trimetazidine. That's assuming this is the standard therapy. In patients with a high heart rate, so you go with the beta blockers or non-dihydropyridine calcium channel blockers like verapamil, diltiazem. If that still doesn't work, you use a combination of the beta blockers and calcium channel blockers. If that doesn't work, you go with the beta blockers and ivabradine to decrease the heart rate. Patients, on the other hand, with a lower heart rate, you avoid beta blockers and you avoid ivabradine. So you start with dihydropyridine calcium channel blockers and you switch that to long-acting nitrates. If the dihydropyridine calcium channel blockers are not working, and then if that doesn't work, you do the combination of the dihydropyridine and the long-acting nitrates. If that still doesn't work, you add either nicorandil, ranolazine, or trimetazidine. In patients with left ventricular dysfunction or heart failure, you start with beta blockers, and then if it doesn't work, you add long-acting nitrates or ivabradine. If that doesn't work, then you add a second-line drug, which is again nicorandil, ranolazine, or trimetazidine. Patients with low blood pressure, you need to be very cautious. Give low doses of beta blockers, low doses of non-dihydropyridine calcium channel blockers. If it doesn't work, you switch to ivabradine, ranolazine, or trimetazidine. If that doesn't work, then you combine both drugs.